I would like to thank the PedirhythmX organizers for allowing me to speak on risk stratification in Wolff-Parkinson-White syndrome. Is it ever safe to defer ablation? Well, just don't defer for too long. Wolff-Parkinson-White syndrome is an electrophysiologic marvel, and likely the reason many of us went into EP. But, like the Tasmanian wolf, is also at risk for extinction, at least in adult EP. In a quote from this editorial, while pediatric electrophysiologists perform a sufficient number of ablations during training to allow for a 95% cure and a 1% complication rate, this may not be true for many adult electrophysiologists. WPW is becoming a pediatric disease. Adult encounters with Wolff-Parkinson-White syndrome are becoming rare, and the skills to appropriately manage it are vanishing, especially in the new generation of trainees. This is a beautiful yet complex disease and requires a clear understanding of many electrophysiologic principles for a correct diagnosis and for effective management. Also remember, when you are ablating these patients, don't forget to admire the beauty of the dragon before killing it. So what are the consequences of running away from an ablation in Wolff-Parkinson-White syndrome? Well, symptomatic supraventricular tachycardia that either persists or develops. There can be developmental changes in the accessory pathway and possibly a change in risk, but not always a decrease in risk. In some children, leaving the accessory pathway leaves them with left ventricular dyssynchrony and its consequences. And I worry that deferring an ablation may allow the child to age out of care from a pediatric EP and either transfer to an adult EP or become lost to follow-up. There may be sports, job, or insurance restrictions on account of the Wolff-Parkinson-White syndrome. And there's a risk of atrial fibrillation and, of course, the small but real risk of sudden death. Which of these is acceptable in a disease where there is a cure? So what are some of the long-term consequences to the adult patient left with Wolff-Parkinson-White syndrome? This is a large Danish ECG study of over 300,000 individuals, in whom they identified 310 with pre-excitation. Those with pre-excitation had higher hazards of both atrial fibrillation and heart failure. The heart failure hazard was driven by right anteroseptal accessory pathways. For younger patients, survival was similar, but there was an association between pre-excitation and death in those over age 65. In this adult study of Wolff-Parkinson-White syndrome survivors, patients with WPW, with and without ablation, were compared. And these were compared to a 1:5 with a control population. Patients had a mean age of 39 years, and the average follow-up for the WPW group was 8 years. When WPW patients were stratified by ablation status, the WPW patients who had not had an ablation had a higher risk of long-term death compared with the WPW patients who had undergone an ablation. What about the long-term risks of atrial fibrillation? It has been a traditional belief that ablation of an accessory pathway prevents atrial fibrillation. This study is a comparison of the incidence of AF after ablation of WPW with the incidence of fibrillation in an age and gender-matched comparison cohort. And one can see higher rates of AF in Wolff-Parkinson-White syndrome patients compared to the general population, and this is despite ablation. Studies such as this challenge the belief that ablation in WPW eliminates risk of AF, but atrial fibrillation is likely better than pre-excited atrial fibrillation. In this study that I've previously quoted, atrial fibrillation risk was higher in the WPW patients compared to the controls, but interestingly, was actually higher in the ablated compared to the non-ablated patients. This makes one question whether the accessory pathway may be part of a syndrome that also consists of an atrial myopathy, or do WPW patients after ablation receive better surveillance for AF? Regardless, These data suggest Wolff-Parkinson-White syndrome patients will require long-term surveillance for atrial fibrillation. Is treating the atrial fibrillation the bone we can throw at adult electrophysiologists after we ablate all WPW? I continue to advocate for a paradigm shift away from the concept that one can leave an accessory pathway with intermittent pre-excitation. There are numerous papers and case series that refute this practice. We recently looked at this in a study of over 1,500 patients, where 244, or 15%, had non-persistent pre-excitation. Non-persistent was defined as intermittent pre-excitation on ECG or Holter, or the sudden loss of pre-excitation on exercise study. 213 of the 244 patients with non-persistent pre-excitation underwent an EP study for risk stratification. In this group, 13% met high-risk criteria and 3 were asymptomatic. Although accessory pathway ERP and the shortest pace cycle length with pre-excitation were in fact longer in the non-persistent group, there was no difference in the Sperry values between the persistent and the non-persistent groups. Looking at the group in a somewhat different way, of the 61 children with a life-threatening event, 10% had non-persistent pre-excitation. I think we should now say that non-persistent pre-excitation does not exclude a high-risk accessory pathway. Why might a pathway with intermittent pre-excitation be high risk? Well, there is this concept of linking. This is concealed retrograde penetration of a propagated impulse into the accessory pathway, and it may contribute to the disparity between the accessory pathway refractory period and the shortest pre-excited RR interval in atrial fibrillation, and may be a confounding factor in the interpretation of non-invasive tests of accessory pathway conduction. Also, there's supernormal conduction, which is conduction that is more rapid than expected, or conduction when block is anticipated. This is relatively common in diseased His-Purkinje systems and in accessory pathways when refractoriness is prolonged, and may facilitate rapid ventricular response in atrial fibrillation in a pathway with a long ERP. This ECG could certainly be interpreted as intermittent pre-excitation, but is in fact supernormal conduction. Another couple of reasons. There is a study that looked at EP study data in the supine compared to the upright position, and researchers found that the upright position actually enhanced accessory pathway conduction. We study patients supine, but they spend most of their lives upright. And finally, accessory pathways can be catecholamine sensitive, and while intermittent at baseline, may have rapid conduction during atrial fibrillation. So what about risk stratification? How good are we? A few years ago, we had a retrospective study of children with life-threatening events. These 96 children were compared to 816 children with WPW who had not experienced a life-threatening event but had EP study data that were available. These box and whisker graphs compared the two groups, with the life-threatening group in red and the controls in blue, and you can see in the blue box all of the patients in the life-threatening event risk group who had EP study data that would not have characterized them as high risk. And in fact, in the children who had experienced a life-threatening event, 37% did not have concerning pathway characteristics at EP study, and 25% had neither concerning pathway characteristics nor SVT. In this study, using the same database, we compared the patients who had experienced a clinical event of atrial fibrillation, thus had a clinically derived Sperry, and had EP study data where risk stratification were derived. The EP Sperry demonstrated only a modest correlation with the clinical Sperry, and there was no correlation with the other EP study-derived functional characteristics. Accessory pathways function differently at EP study compared to the real world. 24% of these patients would have been defined as low risk based on their EP study-derived risk stratification data, but were in fact high risk at a clinical event. This study questions the predictive value of invasive wrist stratification with patients under general anesthesia. However, these data were from a retrospective study and very much enriched for children who had experienced a life-threatening event, and there were calls for validation with this prospective study, and these data are being collected. We are in the process of gathering these. We have an ongoing study with 20 participating centers from 3 countries. The data include children aged 21 years or younger with Wolff-Parkinson-White syndrome. We're collecting demographic, clinical, and EP study data. And like the previous study, for this study, a life-threatening event was defined as sudden death in a child with a previous ECG demonstrating WPW, aborted sudden death or pre-excited atrial fibrillation with rapid conduction, syncope, or hemodynamic instability. To date, we've identified or enrolled, 1,030 subjects with a mean age of 12 years. 55% of male, congenital heart disease, left ventricular dysfunction, and hypertrophic cardiomyopathy are rare, and 20% had an intermittent pre-excitation based on at least one of these measures. Thus far, we've identified 19 children, or 1.8% of the entire cohort, who had experienced a life-threatening event. The mean age of this population was 14. The life-threatening event was the presenting symptom in 58%. Only 2 children had a previous diagnosis of WPW, and few had previous symptoms. The activity of the subject at the time of the life-threatening event was more likely to be rest or routine daily activities compared to athletics. The etiology of the event was most likely aborted sudden death, with 55% of the total cohort experiencing death or aborted sudden death. Encouragingly, the outcome of the life-threatening event was most commonly full recovery, although there were a total of 3 eventual deaths. This bar graph shows a comparison of the proportion of subjects who had EP study-derived values less than or equal to 250 milliseconds in the 2 different patient groups, the red who had experienced a life-threatening event and the green who had not. Importantly, 86% of the life-threatening event group had at least one EP study-derived value that would suggest risk. But that leaves 14% in this group who did not and would not have been identified as at risk. So the preliminary data from this study suggests that a life-threatening event occurred in about 2% of a very large cohort of children with WPW. It was the initial symptom in 58%. The event was aborted, sudden death, or sudden death in more than 50%. The events were not limited to during sports activities. Full recovery was the norm, but death was the final outcome in 16% of those who had experienced a life-threatening event. Most, but not all, had EP study data that would predict high risk. So what are the top 10 reasons to perform an ablation in a child with WPW? Well, you're highly likely to achieve a cure. The risk of a bad outcome from ablation is quite small. Risk stratification, at least to date, is flawed. The ablation eliminates the perceived need for sports restrictions. It may improve insurability, job opportunities, and certainly peace of mind for both you, the child, and his or her family. It eliminates the small risk of sudden death and possibly the decreases the long-term all-cause mortality. Pediatric EPs are better at it, so we should ablate them while they're young. And finally, it's really a great way to spend your day, a whole lot more fun than ablating AV node reentry tachycardia or seeing clinic patients with POTS. When might one decide to run away instead of perform an ablation? Well, probably based on the pathway location and concerns about AV node block. This is very recent data from the Europa registry in 683 children undergoing ablation of any substrate. Over half had an accessory pathway. The success rates were excellent, and the overall complications were rare at less than 1%. They had no AV block, and they did use cryo for substrates near the AV node. In this study, cryoablation was not associated with a less favorable outcome with respect to procedural success or substrate recurrence. In this study from Sweden of over 1,300 ablations of substrates near the AV node, they had no AV block in their patient population. And in this study from the PEDS group at Columbia of 70 cryoablation patients with anteroseptal accessory connections, 6 where there was even a His potential on the catheter at the site of success, there was no AV block that occurred. But what about other locations? Another potential, albeit rare, complication is damage to a coronary artery from radiofrequency ablation within the coronary venous system. This image is from the group in Oklahoma and shows a 90% stenosis at the arrow of a lateral branch of the right coronary artery from an RF ablation that was too close. But when the cryoablation is adopted at these sites, there were no patients who suffered coronary artery damage. However, this group reported the long-term success of cryoablation was less optimal than radiofrequency catheter ablation. Coronary artery damage can also occur with ablation at the os of the coronary sinus or in the posterior septal region. Here's an example of a complete circumflex lesion from RF, eventually requiring balloon angioplasty. In this article from France, they reviewed these patients and concluded that ablation of posterior septal accessory pathways in children does carry a risk of coronary artery damage, but this can be mitigated by three-dimensional imaging merged with coronary angiograms and with the use of cryoablation. Is an accessory pathway ever a good thing? Well, this is the pre-op electrocardiogram of a child that I know who underwent a VSD closure and subaortic stenosis resection at age 6 months. Unfortunately, at surgery, she sustained complete heart block, as shown here. She underwent a pacemaker implantation at about a week post-op. Oddly, and twice, at age 3 and age 6, she had ventricular lead failure and syncope and still had complete heart block, again as shown here. A few years ago, we noticed a difference in her pace QRS, and we noticed a decrease in the percentage of time she was paced in the ventricle from 100% to 21.4%. An ECG with the pacemaker turned off showed sinus rhythm with pre-excitation, and rapid atrial pacing using the device revealed an accessory pathway conduction block at a paced rate of 175 beats per minute, and no evidence of retrograde conduction. Right or wrong, we've left her accessory pathway as it helps save pacemaker battery life and may be actually somewhat protective. There are several case reports of this in the literature, including this case of a child with congenital complete AV block. The child did not have a pacemaker. At age 9, the parents reported that the child had an increase in energy, and an ECG demonstrated 1-to-1 AV conduction with pre-excitation. Pre-excitation was present to a maximum heart rate of 209 on exercise testing, and at 3.5 years, the child still has persistent 1-to-1 conduction. ECGs here demonstrating complete heart block and now pre-excitation. And the authors concluded that this provided the ideal solution to complete heart block. There are case reports of this and similar things suggesting interesting developmental changes in the accessory pathways. Sometimes the accessory pathway gets better, sometimes it gets worse. There are also case reports of very late onset of pre-excitation, sometimes even high-risk accessory pathways, and recurrences of new pathways after catheter ablation procedures. So when is it safe not to ablate? It might be better stated as when is it right not to ablate? Sudden death in WPW, sudden death risk in WPW is low, but prediction methods are flawed. A majority of the time it is safe not to ablate, and the patients don't die suddenly, but is it right since we have a difficult time judging which ones are safe? Leaving a patient with WPW leaves them with more than just a risk of sudden death. There are long-term risks, including heart failure in some. Accessory pathways can change over time, and not always for the better. WPW ablation is likely better in the hands of a pediatric electrophysiologist, so when you defer, don't defer too long. But there are cases that are so complicated and you can't ablate. And it might be, but this might be an ablatable substrate in the future. For he that fights and runs away lives to fight another day, possibly fighting with better tools and better science to approach difficult accessory pathways that may not be treatable now, but could be cured in the future. Thank you.